So the plan is IUI, and where do we go knowing what we know? So, and what's the rationale? And what we know is just 0.1% of sperm, which is deposited in the vagina, reaches the fallopian tube. So it's about 1 in 14 million motile sperm deposited in the vagina reaches the fallopian tubes. So rationale is to increase the density at the site of fertilization, better preparation of sperm, and make it safe, inexpensive, reliable, and simple. Also, we know that seminal fluid is a transport medium for sperm, prostaglandins, and antioxidants, and other cells in ejaculate as epithelial cells, prostate, leukocytes. There is detrimental reactive oxygen species and decapitation factors, and IUI tends to address all these, and you must capacitate sperm for fertilization. And that's what we learn in IVF, is put all sperm into one. And thus IUI is a global procedure. It is simple. Sorry. I think people keep entering, so I'm going to go out and change this slightly. Yeah. So it's simple, inexpensive infrastructure, and higher compliance as compared to IVF. Also, there is one of the challenges you always face with IUI is a high multiple pregnancy rates with ovarian stimulation and poor data collection. In fact, if you look at all the studies done on IUI, the amount of data that we have is so poor that compared to IVF, there's very little that we can tell you what is right or no. So PICO was one of these studies which came in, and it's population interventional comparison and outcomes. And they used the Hunold score, a Dutch initiative validated in 38 Dutch hospitals, not universally accepted as has significant limitations. Ovulation disorders, women over the age of 38, total motile sperm less than 3 million, and less than 1 year of subfertility. So we'll go through what were their recommendations, and then what we can discuss is what each of us does. And I tend to do something slightly different with IUI, and Sachin does something different, and all of you all do something slightly different with IUI, and we will discuss that. So the indications for IUI and when should we treat with IUI. Unexplained infertility of 18 months to 24 months, unexplained plus male factor. So you do IUI plus stimulation in those cases. Sole male factor with poor sperm quality. And here there is no evidence for or against IUI. High evidence, strength of evidence, but still debatable in stuff such as cervical factors. And we lack high quality randomized controlled trials and need confirmation by a trial. So I think that's where IUI comes. So the question now comes up is, do you stimulate or you don't stimulate? And so let's look at the evidence. For unexplained infertility less than 18 months, again, the general concept is do not stimulate. Unexplained infertility more than 18 months, advantages to stimulate, and that's what Cochrane said. Unexplained infertility with mild male factor, which is total motile sperm count is more than 10 million, stimulate the ovaries with IUI. And again, the rationale of stimulation is that, again, we always tell patients, and what do we tell patients? We tell patients that if you have more follicles, your chances of pregnancy is going to be significantly better. So that's something which does happen. And in the study in 2008 suggested that with multifollicular growth, your pregnancy rate almost close to double. So look at what the Americans do. They tend to get between 3 and 4 follicles. So if you look at all the studies of Richard Legros, and when he discussed about what we should be, how many follicles, and they go for a much higher dose of stimulation and get between 3 and 4 follicles. Again, if you what is the influence of sperm quality on outcome? And in fact, here again, research is not helping us. So it's not possible to define very clear cutoffs for pre and post-wash sperm parameters where IUI should be withheld. So I think we seem to know what should be the ideal number of wash sperm, but I don't think we probably know at what stage do you tell a patient that let us not do IUI here. Again, we still need randomized controlled trials comparing IUI versus IVF. And if you have a look at what we did at the Homerton, in fact, we demonstrated that for unexplained infertility, you would get a live birth rate of around 26% after 3 stimulated cycles. While if we compare that with IVF, it came up to around 30%. So it's very, very similar in those cases. What is the best time to stimulate? And if HCG is used, then the evidence says that do IUI between 24 and 40 hours. If you are using a natural cycle, then IUI should be performed a day after LH surge on urine. And the method of triggering and timing in IUI or unstimulated cycle is still open to discussion. And that's, again, we don't know. So much of what we will be eventually discussing is what have we learned through in IVF that we can incorporate and try and convey and use it in intrauterine insemination. And the consensus is that a mean follicle diameter of 18 millimeter seems to be a consensus in ultrasound monitored cycle. So again, is fallopian sperm perfusion better? And here again, IUI seems to be the method of choice compared to fallopian tube perfusion. The next question is, how many inseminations per cycle should be done? And again, this debate I don't think will, forgive me for intermittently because I have to keep admitting people who knock. So the question comes up is the single and double IUI, and we are going to keep fighting over this for some time to come. And the reason is that we still don't know. So at present, we think that for unexplained and male factor, single and double IUI does very much the same. And then there were systematic reviews that favored double insemination, but this was biased because one study, particular study, took almost 70% of the volume. And that's one of the challenges that we will get with any systematic review, that you need one big study to start creating a bias. Again, there were 2 more studies which said there was no advantage from single and double insemination. And further studies are needed in single women and heterosexual women, and because that's not as well set as male factor in infertility. So the question now comes up is bed rest. And I think some of you all love it, and some of us just don't believe in it. And what the WHO says is that 10 to 15 minutes of bed rest is advisable as it improves pregnancy rates. Now, sperm would reach the fallopian tubes in 5 to 10 minutes after IUI. And there was a recent randomized controlled trial that showed no difference between resting or in 15 minutes bed rest. But that WHO recommendation has not yet changed. Second question is, and years ago when I trained, we would say, do 1 cycle of IUI and then take a gap and then do another cycle. And the question now comes up is how many consecutive cycles can you use and can you offer? And at least 3 cycles. And there's no sufficient evidence of how many maximum number of cycles you should offer. And Bensdorp suggested that you can offer up till 6 cycles since it's worth economically. And it's not very well defined or what to do beyond 3 cycles, and it needs more data. Next, we come to semen preparation. And that's again, the question asked is, what is the best semen preparation? And if you look at all the available evidence, there's no advantage between one method over the other. You do swim up, gradient wash, or centrifugation. And in fact, there was one study in 2014 which suggested that in unexplained infertility, the subgroup showing gradient technique seemed to be superior in swim-up technique. So if you start looking at cost effectiveness, and I think I've put something on fertility courses on a BMJ paper, which my andrologist Ghulam Bahadur has written, and that looks at cost effectiveness or a data set quite well. And we should definitely consider 3 cycles of IUI with stimulation in a group of unexplained infertility with total motile sperm count of more than 10 million. And there are several conflicting studies with low or poor evidence. How do we reduce the chance of infection? And the couples must be screened for virology and infection screening, and that is considered to be good clinical practice. Multiple pregnancies and ovarian hyperstimulation, again, IUI should be withheld if you see more than 2 15-millimeter dominant follicles or more than 5 follicles of 10 millimeter at time of trigger. Now you'll realize that that's very much European, the way we manage our cases. The Americans don't seem to believe in it, or probably the Americans seem to generally believe that if you create more follicles, you will automatically give a much better chance of pregnancy. If using gonadotropins, use less than 75 ideally for stimulation. Clomiphene, again, is an acceptable alternative, but seems to have a lower pregnancy rates. And both can be combined. And again, as I always tell you in all our teachings is, if you don't have the evidence, when you say, can I combine with letrozole and can I combine it with clomiphene and gonadotropins? Yes, you can. It makes theoretical sense and it makes, physiological sense, but if you just don't have that evidence. Again, antagonists make our life simple. You can predict the exact time of ovulation, but they don't seem to improve live birth rates. And if you see a lot of follicles, then aspirating the follicles before doing IUI could be one option, but that in fact increases the cost of the treatment. If you again look at the perinatal outcomes following IUI when compared to normal conception or IVF, it seems that there is a higher rate of preterm birth and IUGR and singleton and twin pregnancies when using ovarian stimulation when compared to natural conception. And this is often associated with multiple pregnancies. And in fact, we just don't know why that happens. And we think there are endocrine changes. We also think that the procedure itself and underlying infertility may be leading to some amount of perinatal outcome, and counseling is essential. So, we often talk about endometrium, and we're very much concerned about the endometrium. In IUI, that doesn't seem to be a good predictor of success. So female age is one of the most important factors, and as a woman crosses the age of 40, oocyte quality is significantly affected. Again, as men get older, the quality of sperm tends to start going down. Endometrial thickness, again, is not a good predictor of success. Whether or not you do Doppler, I tend to use Dopplers for a very different reason. But again, it is very much a touch and go. BMI and obesity, again, extremes of weight tend to lower the chance of pregnancy, and smoking, again, tends to have a negative impact on IUI success rates. So that's in general, and I think that's in short what we covered about IUI. So if you have any questions, if you want to come out and tell us your question, then what I would suggest is put your hand up, and I think there's a way of putting your hand up here. Or if you want to type it, and then we will answer. So we'll take any questions. I think, Sachin, I will put you on.
Yeah. Yeah, I think before I just wanted to share two things before we go ahead with the questions. One common question, which I think it's quite relevant also, is should we be using antagonist in our IUI stimulation protocols? There are data and there are papers who talk of on either side of the story. There are a few papers say that well it doesn't make a difference, and a few papers say that makes a difference. Statistically significant higher ongoing pregnancy rate are not obtained in most of the papers, which are published by Contigue or Cossingini 2013, etc. Now, but what they have noticed that there are a few things which we need to narrate here. One is about 24% of the patients who are undergoing gonadotropin stimulation for IUI would notice premature luteinization. So the progesterone level would go up, number one. Number two, suppose you add antagonist. Obviously, the cost of treatment will increase. The amount of stimulation may go up. There is more chance that you will have multifollicular follicles, because if you don't use antagonist, the lead follicle will always tell you to give a trigger. And in the bargain, all the follicles which are following the lead follicle will lose their opportunity to rupture. So with antagonist, that advantage is there. So your chance of multiple follicles is high. Then what is an ideal setup of an IUI to get the best success rate, since we want to use antagonist? What studies are, this is a study by Mazaruf, if I'm not mistaken. I probably could not be pronouncing it properly. And he says that there should be two follicles beyond 16 millimeter, and the estrogen level should be beyond 500 picogram. And that's an ideal scenario to go ahead and do an IUI. So if the requirement is two follicles, I think there would be definitely a subgroup which would benefit by giving an antagonist injection. I was just going through one of the randomized trials where there was only 80 patients, 40 in each group. In one group, they give antagonist, and the other group, they just did a straightforward IUI. In the group which they gave antagonist, their ongoing pregnancy rate per cycle was 16.4%, and the cumulative pregnancy rate was about 24%, while the ongoing pregnancy rate per cycle in the control group was about, I think it was about 8.1%, 8.1%, correct. And the cumulative was about 11 or 12%. So just for the sheer fact that with use of antagonists, we are going to increase the number of follicles for IUI. Probably that's one of the reasons why we see more pregnancy rate with that. Though statistically not significant. This statistical significance part is not being achieved maybe for you need a real large data, because the IUI success as it is so low that you need to have a very big data to compare to show a 5% change in the success rate as such. So, that would be one of the reasons why the statistical significance is not there. But case to case, you can make a difference in your protocol, whether you want to use antagonist or you don't want to use antagonist. That was one thing. The second is when it comes to the technique of semen washing. See, we till the time we do IUI, probably most of us don't do a semen DNA fragmentation. We just go ahead with the semen analysis and take a call. So if there is only oligospermia, or a normospermic samples, I think with normospermia, the evidence says that swim up is okay. But whenever there is a problem, density gradient definitely has more advantage. So going to density gradient is more appealing than this. I don't have personal experience of microfluidics for IUI, but what the literature says is when it comes to DNA fragmentation, separating the sperm, which is with a fragmented DNA, microfluidics is the best. Post microfluidic semen separation, the DNA fragmentation has been noticed in 1%. So that's the best method to separate, because probably there are 2-3 mechanisms by which the sperms get DNA fragmented, and even the swim up as well as in the density gradient, you will end up selecting the DNA fragmented sperm still. So microfluidics, since it allows test the functionality of the sperm to go from point A to point B, and probably a DNA fragmented sperm will have a less mitochondrial activity and less energy to reach that point B, and that's maybe one of the reasons why you get a better DNA sperm when you use microfluidics. But personally, I'm not using microfluidics. Anybody of you is using it, please do share. I just wanted to share these two things, and we are open for questions.
Yeah, so there are a few questions here, Sachin. So again, we think that total motile sperm count seems to be the better way, or has a better predictive value. So if you tend to look at almost all the studies now, they look at total motile sperm numbers in terms of making the decision.
Actually, 2010 WHO says that you can do it beyond 1 million, but believe me, the success between 1 to 10 million is pretty low, very low. You need a good amount of conviction to and morale to keep up doing IUIs again and again. So that I do face a very low success rate when it comes to a TMSC less than 10 million. If the TMSC beyond 10 million is something, well, you can at least keep up to the pregnancy rates.
So the second question is, how do you prevent asynchronous follicular development? Now, that's what happens in nature. In nature, recruitment is asynchronous, and recruitment, and so in very simple terms, is how do you override asynchronous growth? And the way you override asynchronous growth is by in fact, increasing stimulation. And the more you stimulate, you see more follicles recruited and more synchronous growth. So as soon as you decide to use a mild stimulation, the aim is ovulation induction. And ovulation induction will lead to growth that is asynchronous. Can you explain how long do sperms are viable after IUI? Sachin, your guess, I don't know. I don't think anyone knows. In fact, there is one video done by my andrologist, and it's worth seeing. It says, how long do sperm survive inside the body? And in fact, he concludes that we just don't know the answer. But what is quite funny is that the video has taken close to 250,000 views, and there are a lot of people who have posted such funny comments that it's quite funny. So we don't know. Again, do you? I don't do Dopplers.
Actually, there's one paper, Anil, which is headed. It's techniques of IUI. Is it time for a change? I think this paper was published in Human Reproduction in 2017 by Lemons et al. And what they said was the storage temperature after you're done an IUI. So processing, lower temperature of storage is less harmful. Vacuoles in sperm head is common if stored for 37 degrees for a longer time. So don't keep the washed specimen in the incubator for a longer time. And capacitation related events are blocked temporarily because at lower temperature. And what they said is your collection to insemination timing should be less than 90 minutes to get an optimum IUI success rate. So that these are things which have been recommended in this paper.
Sachin, could you take the next question? I'll just get another.
Is it when shall we do double IUI? Any indications, sir? Actually, the literature just say that single well-timed IUI is good enough. There is really no time to do no need to do a double IUI. The papers which did show the double IUI makes a difference was the patients with oligospermia, wherein doing 2 consecutive IUIs on 2 days could make a difference. I have observed, but this is just an observation. This is no. I'm not telling you a paper here. That I've seen people doing it for donor IUI, where you want to have early success because the next choice is pretty expensive. So I've seen people doing double IUIs for that. Semen collection, when the total motile sperm concentration is less than 3 million, that makes a difference. So having 2 semen collections done consecutively or beyond 40 minutes, that's again a Ghulam Bahadur paper. If your total motile sperm concentration in the first, this is less than 3 million, you could be doing. Otherwise, double IUI per se wouldn't make much of a difference.
See, in terms of Dopplers, I'll tell you what, let me just share the screen. Now, let's look at it. And that's a Doppler. So from a assessment point of view, if you're going to measure it, and I'll be sure that considering how small these vessels are, you're not going to have uniformity of measurement. So I'll tell you what I do. My triggers are based on how good is a perifollicular flow, because let's go back to physiology. Follicles that are closer to ovulation, and almost all the flow is peripheral in pre-ovulatory follicles, and in post-ovulatory follicles, blood flow is central. So that's how it changes in anatomy. But what you're looking for is you're looking for a good perifollicular flow this way. And that basically tells us is that the ovulation may be, it may be close to ovulation. And that's all I take. I'm not a great fan of Dopplers.
Yeah, there's one question about endometrium. Though ET is not predictor, but still we need to have a cutoff like 7 millimeter. I think that's really not necessary. Let's say your ET is 5.5 or 6 millimeter on the day of trigger. By the time you give HCG, then rupture will take place around 36-40 hours later. The embryo will form. By the time a blastocyst or a morula comes all the way back to the uterine cavity, another 4 days will go by. So, and you are not calling the patient back. So my advice would be, if you see an ET less than 6 millimeter on the day of trigger, call the patient 4 or 5 days after you're done an IUI and have a look at the ET. The ET probably could have gone up because it is a nice corpus luteum which is giving estrogen as well as progesterone. The ET would go up to 7 millimeter or beyond. Then you are fine. This is absolutely okay. But let's say ET still maintains low. It still maintains 5 millimeter or 6 millimeter. It's not increasing beyond that. And I think probably you should think of ruling out a local pathology by doing a hysteroscopy next. So that's how I look at it. But all the papers are showing that ET is not a great predictor of an IUI success.
Again, what is the maximum time limit? Lanil is asked, what's the maximum time limit for IUI? I think again the evidence goes both ways. You know, up till 6 cycles makes sense. But in fact, I doubt if any of us does it for more than 3 cycles. In heterosexual couples, by the time you have done 3 cycles, I think the patients are a bit fed up and the doctors are a bit fed up, and almost all the interventions seem to occur after 3 cycles. So, though for unexplained fertility, if you look at a Dutch model, and up to about 6 cycles are possible. Do you do double IUI for any reason? I'm a bit, on a personal practice, I am a bit pro double IUI, and that's for a reason, is if it is a mild male factor. So I'll tell you what I do different often, and I sometimes do IUI for poor responders, for women who have a very low reserve, where IVF may not be possible, and there isn't a male factor. I do it for women with a slightly thin endometrium, and that's for a reason, and I'll explain that also. So, and what do I plan to do is, if it is a male factor, I do consecutive samples. So I'll do consecutive samples twice, and I believe sometimes it's good to make the man work a bit harder in all this. So what I'll do is I will get them to produce 1 sample, and I'll do that. Let's say I'll trigger at night, and let's say 9 o'clock, and next day at about 11 o'clock, that's 14 hours later, I do the first IUI. And I ask for a consecutive sperm sample, and I combine both the samples and I do an IUI. Next day, I do another IUI and I combine samples again. So in effect, what I've done is what in nature would not be possible. I've increased the number of total motile sperm available. Is there evidence? No, and that's my personal practice, which I would do it. The other reason is, why do I do it with thin endometrium? Again, as I had said, in IVF, embryos are grown in a low oxygen environment. So when you take those embryos and you replace them in a thin endometrium, where oxygen environment is higher because the endometrium doesn't act as a buffer and the baseline arteries are more exposed, embryos don't implant. But in IUI, that doesn't happen because there's no such low oxygen environment in an IUI. So, you know, and that's the reason why you'll see a better pregnancy rate in thin endometrium. Yes, Sachin, do you want to?
Now, I would say this question about how many IUI cycles should be done, I think it's completely individualized to the patient and the indication you're looking at. There are situations I'm sure all of you also face that these IUIs for a futile increase in the pregnancy rate, but you just have a pragmatic approach. You say, well, your IUI could have a success rate of 2 to 3% because you're so badly oligospermic, or you have an endometrioma, this means surgery done, all those different reasons, while your IVF and ICSI could be a better result. And out of the discussion, after giving a complete information to the couple says, well, we don't mind going for one cycle of an IUI, just try it out. Sometimes it's a pragmatic approach, that way. But generally, I don't cross generally 4 IUIs, and after that I start. If I feel there's some reason ahead beyond that IUI can correct. So I generally don't do it beyond 4 IUI. There's a very interesting question, two
No,
questions.
I think Kasturi has asked, do you assess morphology?
Yeah, that's it.
What is your take on morphology in an IUI sample?
Uh, Firstly, from the IUI point of view, I don't know. I don't go greatly by the morphology. What does the literature say? I just had I came across one paper which did talk about assessing the morphology and using MAX for that magnetic activated cell sorter, and then having a better pregnancy rate compared to doing an IUI without doing a morphological testing at all. That's just one paper. But morphology, whether it makes a difference from the this point of view, I think let's not dissect it a lot, but there could be some absolute things. For example, like things like globazospermia, and these are the ones where your IUIs will not work. Otherwise, morphology I wouldn't give a lot of importance in when it comes to IUI and its morphology.
Again, donor IUI or frozen samples. In fact, if you look at the evidence coming up from in same-sex women or in single women, frozen samples tend to give a significantly high pregnancy rate. So I gather that freezing of sample, as long as it's done well and you have a reasonably high motile sperm count, should not make a huge difference. I think Sushil has asked, in COVID patients, will IUI in COVID patients be indicated? And I think we just don't know. From an IVF perspective, I don't think it makes a difference whether you do IUI or IVF in a post-COVID. In fact, now almost all treatments have stopped. And in fact, in Europe and the United States, we can't do even ovulation induction. So I don't think it makes a difference. I think you'll need to look at the indication for IVF and then make a plan. Do you use clomiphene in preventing premature LH surge instead of antagonist? Yes, you can. The question is, if you're doing IUI, the success rates are much lower because one is we think that it affects the endometrium. So in fact, if you have a look at, there's a paper I had presented and where they had done the stair-step protocol of clomiphene or the prolonged clomiphene treatments. And so what happens, you see generally, even when with a trilamina good endometrium, you'll see about 10 to 15% drop in the endometrium. And that is a negative impact of clomiphene. But if you're using it on IVF, I think it's brilliant. So some of my low responder protocols will have clomiphene for 14 days. And that reduces the chance, the risk. So the risk is about 2.5% in one of the largest trials of premature LH surge while on clomiphene. Should you downregulate before IUI? Again, the problem is that ovulation, there is no evidence with ovulation induction and downregulation. And there's no, again, evidence that pre-treatment allows a better synchronous growth in ovulation induction. So in IVF, that data is different. And if you pre-treat or if you downregulate, your synchronous growth is much better whether you use, if you pre-treat or use a downregulated cycle. But the problem is that I genuinely dislike long protocols because once in a while you'll see an over response and that can be a disaster and that can be very risky. I don't know, Sachin, do you want to say anything about Dopplers? Because I don't do blood flow.
I don't do Dopplers at all in my IUI practice. So I wouldn't be able to comment on that, although it's one of those great fashions in India to do Dopplers. But I wouldn't comment on that. I just look, I just look at the endometrium. I only go by two things, the PI index of the uterines and the zone 3, zone 4 blood flow. But when it comes to follicular Doppler, I don't do it in my practice. This is one paper, this is about pre-treatment. Well, giving a GnRH agonist for IUI, I think it's too much of expenditure, so I wouldn't do it in my practice. From maybe 10 years back, 1 or 2 cycles we might have done. But giving pre-treatment, well, there are a few papers, again, olden papers talking about giving pre-treatment like progesterone, like macronized progesterone, and even OC pills before doing ovulation induction in PCOS women. those are the papers published when a lot of the LH was having such a huge importance in our practice. Probably now we don't think much about LH. We understand that LH could be high and we just override it by giving a proper gonadotropin stimulation. One small hint is instead of using HMGs, simple HMGs, use as many as Gonal-F or Menopur for your patients when you do IUI. It is still cost effective because you can reduce the dose. You can give it a smaller dose and they are highly potent. In a smaller dose, they act very well. And I think you could have a much better pregnancy rate. So concentrating more on the ovulation induction, going a little with these recombinant preparations or Menopur preparation like Menopur would be better, I feel, to these things. Yeah, this somebody's put a paper on morphology. It's difficult to download, but I was just going through one more paper on morphology, and they all said that uh, if the total motile sperm concentration is beyond 10 million, uh, the morphology wouldn't make a difference. But if it is less between 5 to 10 million, it makes a difference. That was the paper said. Is there a persistent IUI dual trigger does cause rupture? Does agonist effect? Okay, I think we can just uh, downsize the question to: will you use dual trigger in patients of IUI? Anil, what is your take on that?
In fact, I use dual trigger in all my IUI cycles, and I'll tell you a reason why. About a year ago, I started using a dual trigger in my ovulation induction cycles with clomiphene and letrozole. And I started seeing uh, uh, day 21 progesterone much higher when I had used a dual trigger. And again, I can't prove it, and I think it's very difficult to prove this. I believe that the higher the rise of LH and FSH does give a better corpus luteum. And that's the reason why I use a dual trigger. In IVF, I tend to use an analog trigger in my private practice. And I tend to, again, it forms almost 60% of all our treatments in IVF at my NHS hospital. But the question which we need to ask is, the luteinized unruptured follicle, I've always classed about this is, you see a lot of it and I don't see much of it. So either the women I treat are different and the women you treat are different, which is likely, but also the way so why do you see unruptured luteinized follicle? And which is the most, the drug which is probably causes most luteinized unruptured follicle, and that's clomiphene. So if you move to HMG or you move to FSH, you're very likely to avoid a luteinized unruptured follicle. And if you trigger with it, then your chance of getting unruptured luteinized follicle are much lower. The second thing that does happen is that if you start seeing a follicle that reaches 20, 22 millimeter and may get luteinized, and there's sometimes no way of knowing it. The only way you'll know about it is you will not see a rising in LH. You'll see a rise in progesterone, but you won't see a rise in LH. And that is the way you mark it. I don't scan a few days after the IUI because I think it's chasing a follicle that has ruptured, and it's very difficult to find out a difference between a corpus luteal cyst and unruptured follicle. So, in fact, I'll tell a patient, why don't you do a serum progesterone? And if a serum progesterone is low, that's again a sign that the luteal phase is disrupted. And the luteal phase, the progesterone is poorer, the luteal phase function is poorer. And again, it comes down to LH type activity. And that's what luteal phase is. Luteal phase is LH type activity. Sachin, what is your cancellation process? What cancellation process would you use?
My cancel, I would cancel only if I see more than 4 dominant follicles. And my cancellation process would be to give a loop-right trigger. I would give a GnRH agonist trigger and tell them not to have intercourse.
Again, how do we avoid premature ovulation occurring in PCO patients? When to check LH levels and when to use an antagonist?
Actually, I'm not able to find out that paper. I was just looking for that. But whenever you see more than 2 follicles, I think there's nothing wrong in putting antagonist, because that's the way you start antagonist. But then you should have a policy that you are calling these patients very early for your scans. If you're calling them maybe day 7 for the scan, probably you will have that window to add the antagonist, because you will be, this is not like a fixed protocol. You'll be doing a flexi protocol where you look for the size of the follicles touching 14 millimeters and then adding an antagonist. So you would call a patient on day 7 onwards and then start antagonist and continue the stimulation and give HCG trigger. But this is going to be tricky because the paper which I saw about a randomized trial about antagonist in IUI, it talked about, they had about a cycle cancellation of 6%, no, 6.5% to be very precise. And 40% of these cancellations were because of more than 5 follicles development. So whenever you're using antagonists, your chance that you will have a multifollicular development will be high.
Again, another question we could ask is, do you use estrogen as luteal phase support? Again, in IUI, there doesn't seem to be any added advantage by using estrogen. Almost all the studies have essentially looked at estrogen and found that there's no difference. Again, if you use, again, if you looked at the largest trial done recently, do you give luteal phase support in a stimulated IUI cycle? The answer is yes. The evidence does suggest that it has a slightly higher pregnancy rate, and that's the reason why you can give it. How to prevent reflux during insemination? And I'll say this race, either you can change the equipment, and they're equipment come with balloons, but I think they just make it more expensive and more painful. One option is I take longer to do an IUI than I tend to do an embryo transfer, and I inject very, very slowly. That probably lowers the chance of having a reflux. In chronic low dose protocol, maximum, how long can you wait to see a dominant follicle? And that's a good question, because how long can you wait? And usually I'd say the chronic low dose protocol is 14 days of uninterrupted FSH. And if you don't see something for 14 days, for another 7 days, you add 50%. So if you start with 75 international units, after 14 days, you change it to 112.5. And then after that, for 7 days, to 150. The question is that, and in fact, studies have gone up till that 28-day period. The question is, cost increase, success rate don't dramatically increase. So what I would suggest is, if you don't see a change, I think it's better to cut down costs and then combine it with either clomiphene or letrozole and try the same thing again, or try adjuvants like metformin, which can be used during that treatment. Can we legally do IUI for a single mother in India? I have no idea.
Same here. Even I don't have the idea of the legal issues there. Probably I've never faced a single mother willing for a donor IUI in my place. So
what does a single mother mean?
In a sense, a lady who is not married and desiring a donor IUI to have a baby.
Yes, so
it should be fine. But
in fact, I don't think it makes a difference.
I really don't know. Logically, it still appeals to me. I think Kasturi has already replied, we can do it, so that's fine. And somebody said it is not allowed. Okay. So there is a confusion. And when it comes to chronic low dose protocols, again, it really gets frustrating when you go beyond 12 doses, and it becomes so difficult to explain the patient because you're rising on the cost, and unlike in the Western world, our patients are spending from their own pockets. So it does become very difficult. But I generally go till about 12, most of the patients have gone to 12 doses, very rarely till 14. And if I don't get it, I just stop it. And depending upon at what dose I've been trying. Not many women respond to a low dose of just 50 IU. I feel better or beyond gonalef for most of our Indian population.
So I think next week, Amit is doing a talk on the endometrium in recurrent implantation failure. And then Sachin, you want to do a talk, a discussion on male infertility, or?
Yeah, we'll be doing certain, mostly on andrology. I'll be doing one on andrology.
I think everybody is in India. Everybody is a bit confused about. I think there's a confusion about can single women be treated. I don't think there's. I don't, in the UK that doesn't make a difference, but I'm not entirely sure why they can't be treated in India. Anything else?
What I'll do is I'll post some papers upon the morphology and IUI, because that's something probably we'll just revisit when we do this before we go to the next. And before that, I'll just put one paper on that across to you.
Anything else anybody wants to ask?
When can we start seeing patients after the knockdown opens? The very next hour, I suppose. Max use in IUI. Very infrequently, I've been using it. Again, it is something which is more used in ICSI sperm preparation than in IUI. But again, I'll have to dig a paper if there's just some paper which is talking about max making a beneficial there. But I think there would be some people which will always say that, because it's a very recent technique, unless a systematic review comes analyzing 3-4 papers. Antibiotic after IUI, not in my practice.
No, I don't think there's any role of doing antibiotics in IUI. So I'll say something which is very controversial, and I think it's, I'll say if you want, you use a dual trigger for your IUI and do your progesterone levels. And I think those I think some people have tried it and it does make a difference. And I think it's because you're moving it closer to nature. Now, in IVF, you get probably good oocyte quality. And again, we have not proved it as yet, but if you're going to get it, why don't you routinely use a dual trigger? And I think it makes it cheaper. It's not very expensive. The Lupride or Supercure is not very expensive, but I'm certain that you will see less of unruptured luteinized follicles. You'll also see a slightly better luteal phase going on.
Afil, thank you so much, Anil.
So probiotics and prebiotics role in IUI. Again, it's not been proved. A lot of stuff is taken, but very little is being proved in terms of its efficacy in improving IUI success rate. And again, you have to remember that we have less data, and as much in IUI, and the amount of data is less. The general rule is if you have more follicles, pregnancy rates are higher. You have to balance the risk of twins. The more motile sperm you have, your pregnancy rates are better. Good gonadotrophins, pregnancy rates are better. If you add luteal phase support in a gonadotrophin stimulated cycle, pregnancy rates are better. So if you keep it to those few points, you will see a better chance of success. And second thing is, think of consecutive ejaculates. Does double ejaculated in IUI cycles? Again, the data is small. So what do you lose? And if you say you need a total number of motile sperm should be more, then why don't you ask the man to produce twice within the hour and combine the sample and then see? I don't think you lose anything, but you're giving the best possible chance to this lady. Is luteal support a must during IUI? No, it isn't. But if you have a look at the systemic analysis in IUI, which was recently published, and what they suggested is that in a clomiphene cycle and a letrozole cycle, you do not need luteal phase support. But in a cycle in which you use gonadotrophins, there seems to be a small but a significant difference if you give luteal phase support in a form of vaginal progesterone. So I think that does it. I think we've managed to complete So anyway, thank you very much. And we'll catch up next week again. And hopefully, if you have any questions, just drop me a line if there's anything specific you want to discuss. If there's something unconnected to talk and you want to discuss, more than happy to take questions. And
Definitely. This light on medical and surgical, that
yes, I think, Sachin, you're doing the talk, isn't it, on male infertility? Anyway, thank you very much, and we'll catch up next week. Bye-bye.